IOL Power Calculation session. The moderators, Giacomo Savini, Italy, and James Katz, USA. We welcome the panelist, Gede Pardianto, Indonesia. And featuring the speakers, Thomas Olsen, Denmark. Elizabeth Yu, USA. Naveen Rao, USA. And Richard Davidson, USA. Organizers: Sergio, Canabrava, Brazil, and Ashvin, Agarwal, India.
Welcome, everyone. It's so great to be part of this meeting with both of you and Dr. Savini. So thank you for inviting us all. We have wonderful speakers today about IOL calculations. We're very excited, as Ashvin said. We want to get the most accurate calculations for our patients, whether it's primary virgin eyes or post-refractive LASIK or whatever procedure. So we're very interested in hearing what you have to say, all the speakers, and have a nice discussion about this today.
Yeah, and I would like to start before asking Dr. Olsen from Denmark to give his talk. There's a poll that the organizer asked me to give. So there's a question to all participants. And what do you feel is the most unmet need in the field of IOL power calculation? There are three very interesting answers. First, a simple and accurate method to calculate the IOL power after corneal refractive surgery. And this is something that we all need, of course. Second, even more important, a formula leading to a prediction error lower than half a diopter in more than 95% of unoperated eyes, something that we can already achieve with excimer laser, but not yet with IOL power calculation. And third, would you like to have an instrument allowing the surgeon to understand the source of postoperative refractive surgeries? So I asked the participants of this session, those that are listening to us, to give their answer, and it would be interesting to know. In my personal view, I think that most researchers are now focusing their attention on point 2, try to get as close as possible to 90–95% of prediction error within half a diopter. On the other hand, it would be really a dream to have an instrument that helps us to understand what's wrong with the refractive surprises. I don't know, Jim, what do you think about this?
Well, I completely agree that number 2, the one that you talked about, a formula leading to less than half a diopter of residual refractive error in greater than 95% of patients would be the correct answer, the one I'm most interested in, versus a simple method to create IOL calculations, or even this an instrument allowing post-refractive and surprises and things like that. I think the most important is getting most of our patients, or 95%, within that range of what we really want to get. But all these are interesting topics.
Yeah, I agree. I think that we can start in the meanwhile while we are waiting for the answers from the participants. We can start with the first talk, and I would like to invite Thomas Olsen from Aarhus, Denmark, to talk about current improvements in IOL power calculation. Thank you, Tom.
Unmute.
You're on mute. You're on mute, Thomas.
I have to unmute myself. So now it's all right. Happy to be here. This is a fantastic event on a worldwide basis. That's very fantastic. So I would like to talk about the IOL power calculation and the current improvements that we are seeing today. I hope you can see my screen right now. So what are we facing? First of all, I have some financial disclosures. I do a lot of refractive lens exchange cases myself, and I do have some financial interest in this IOL power calculation matter. So now I wanted to do this differently than maybe you have seen often in the past. So rather than just punching you with a lot of data, showing the accuracy, I will try to give you the logics behind current and future improvements. Before we do that, we have to recall how the thin lens formulas work. You have the K reading, you have an axial length, and then you have this concept called the estimated lens plane. And from that, you can calculate the IOL power in the eye. It seems quite simple, but as we all know, there are some unknowns in this formula that really makes it tricky, not just like that. So what is the real world doing? Well, many formulas out there are using sort of black boxes, artificial intelligence, or whatever you call it. And it works like that. You have a model, you use it, and you get the results. And then you correlate the results or your error of your predictions with your model, and you optimize. And in this way, you can get pretty good results. But nobody's really knowing what's going on behind the scenes. So I would like to take another approach. I call it a divide and conquer. I know it has been used in other aspects, but anyway, the main issues that we are facing today is really, we need to get the cornea right, and we need to get the ELP right. So remember, for the formula to work, we should make sure that the corneal power is right. If we make an error in the corneal power, we need to make a correction at the end. So it's very important. It's a first step. So what do you mean by the corneal power? Well, most of us will go for the keratometer and take a reading of the front surface of the cornea. But as you know, that's only part of the story. There's the back surface as well. And how do we calculate the effective corneal power from the anterior readings? It's getting more obvious. It's not that easy as we used to think. And especially if we go to the post-LASIK cases, you have a post-LASIK cornea where the anterior surface is flattened, but the posterior surface seems to be more or less the same. Another situation with the archaic cornea, where you have a flattening on both surfaces. So we need to know more about the posterior surface. And we are getting more instruments to answer this question. It's not a new invention. Actually, more than 100 years ago, they were calculating the back surface of the cornea from the Purkinje-Sampson images. Now we have slit imaging. We have OCT scannings, and they are coming in great numbers. To understand the corneal power, I think ray tracing can help you understand what is going on. And if we take the example by the Pentacam Scheimpflug photograph machine, it can export not only the anterior surface data, but also the posterior surface of the cornea, so they get a total elevation map, the contour of the entire cornea, not just in the front, but also on the back surface. And if you want, you can actually import those data into a optical engineering software program, a commercial optical engineering software, a very known one called the CMAX. I have done that in this case. This is a real case where you have the front surface here, you have the back surface, and we have done some triangulation to get the data into the CMAX system. And then we use a lot of rays to go through the system, and we look for the focal point. The focal point is actually a measure of the effective corneal power. So if we look at the best focal point, this is the effective focal point of that cornea. And then we can back calculate the effective corneal power in this case based on real measured data. If we do that in a number of cases, that's normal cases I'm having here. This is ray traced corneal power, like I told you, compared with the power that you get with a keratometer. The K reading of the keratometer is too high. You know that because the index of the keratometer is 1.3375, and it's too high, almost 1 diopter compared to the true corneal power. Maybe
we are close to the end. So
is it all right?
we had 5 minutes, so you need to shorten.
Is it all right? So the
Yeah,
next
yeah.
issue is the IOL position of the ELP. And as you know, the optical biometry is getting so accurate today. So the source of error from the optical biometry is almost nothing. What remains is actually the ELP, which is the main source of error besides the K reading. And if you look at the different formulas out there, there are many approaches how you can optimize the ELP. Many formulas use a lot of parameters. You can see the Holiday 2 is using the axial length, K rating, ACD, length, and also the white to white, the refraction, or maybe the age of the patient. So there are a number of different approaches. My approach has been very simple, actually, because I go for the biological anatomy of the crystalline lens, which can be measured by pre-op biometry today. And then we go for the location, the physical location of the IOL after surgery. This is a scan from the lens stab preoperatively. And here's a post-op situation in the same patient. As you can see, the IOL is ending up somewhere inside the crystalline bag. No wonder, because I put it there. But if you measure it, you get the location of the IOL as the orange dots, the anterior capsule, that's the blue dots, and the green dots, that's the posterior capsule. So here you can see it's right in the center, maybe more anterior than posterior. And if you plot it according to the axial length, you see there's some relationship with the axial length. But most importantly is a constant fraction. The IOL position is a constant fraction of the thickness of lens. So here we have another approach to predict the location of the IOL after surgery. We got rid of the K reading, the axial length, indirect predictors, and we are left with the ACD and length thickness. That's the formula that I call the C constant approach. And it's not depending on the K reading nor the axial length. That's very important when you go to post-refractive cases. So what is the error that we get? Well, I have the opportunity to have access to one of the largest databases published. That's the Miller study published some years ago. And here you can see comparison between different formulas. We have 13,000 cases with the Alcon SN60YF. And you can see all formulas do pretty well in normal axial length. There are some higher errors in the short axial length. And if you go to the extreme high myopic eyes, you see a big difference between different formulas. I was fortunate enough to see that our approach was doing very well, also in the very long eyes. Actually, we are down to 0.3 diopters as a mean absolute error in these eyes. Number of cases within half a diopter. Well, we are approaching in this case series 82%, as you can see here. And I have to say, these cases are a mixture of different clinics and different surgeons, and it's cataract-based cases. In my own series, I'm getting more than 90% of all cases within half a diopter. So I would conclude that the IOL power calculation can be improved if you follow a divide and conquer approach. First, get the corneal power right, then get the IOL position right, or the ELP, and notably, it works also in post-LASIK cases. So the rest is just physical optics. And if there's one home message here, I think IOL power calculation is no magic. It's just logic. Thank you very much.
Wonderful. That was a great presentation, Dr. Olsen. It's very complex and very complete with a great, great take-home message. Should we move on to the next one and then discuss further the cases? Is that a better way to do this?
Yeah, let's move to the next. Let's finish all speakers and then move to the.
Let's go ahead and do that. I think there's going to be a lot of questions for Dr. Olson's. And next is Elizabeth Yu speaking on the management of the residual refractive error. So we'll have Liz take over from here. Thanks. Maybe we could start that. Unmute. Or turn up the volume.
Can you
During this section.
Thank
There
you.
are so many different causes of residual refractive errors, whether it's going to be an IOL power miscalculation due to effective lens position, or toricity miscalculation, a post-LASIK eye, or malposition of a lens. All can result in that residual refractive error. What will be so important is evaluating that post-operative surprise. And this really means after the patient is completely finished with their actual medications and drops, you want to repeat all the diagnostics and compare pre to post, both topographies as well as any diagnostics of the macula. You want a very accurate manifest refraction, and as this OPD dilated image shows, identifying if it is a toric lens implant, where the actual IOL is compared to where the steep meridian should be. And there are different tools like Axis Assistant to identify the meridian of your lens implant, kind of like a compass, and different programs in order to help determine whether that lens should be re-rotated. These are examples of various reasons of ocular surface disease that can result in residual refractive errors. This patient who had preoperative, very subtle EBMD, as you can see here on the lower left side of the image. After 15 days of toxicity between the drops and such, you can see a much worse picture where subclinical basement membrane dystrophy became much more clinically relevant. Salzmann nodules can sometimes be better identified with a negative staining, as you can see here at 10 o'clock. And this topography of such a patient does demonstrate that even though it is peripheral, it can truly manifest with a refractive effect with flattening that goes into the center of the visual axis. And what a difference it makes to actually manage that Salzmann nodule with a superficial keratectomy. There are various treatment options available: relaxing keratotomies for those with mixed refractive astigmatism, laser vision correction. If the toric IOL should be realigned, that should be a goal in mind, especially if it is a mixed astigmatism. A lens exchange or a piggyback lens can be all considerations. And which corrective option you choose should depend on a few of the following. How large is that refractive error, and what type of error is it? Is it a residual mixed astigmatism? Is the spherical equivalent off as well? Are they on the plus side or the minus side? What comorbidities actually exist with the patient, including irregular corneas and dry eye, and then a patient personality assessment and tolerance to that refractive error. For those patients with a residual mixed astigmatism left over, if it is a small amount, this is where a keratotomy can be very helpful to relax that astigmatism. But if it is a larger error, that larger error should be corrected with either laser vision correction, a toric lens realignment, or to consider an exchange depending on how large the error actually is. This is a great example of a patient who was determined that their mixed astigmatism with a rotation of the lens implant clockwise 48 degrees into the proper meridian would actually neutralize that residual refractive astigmatism in this patient. Timing is everything when considering like a laser vision correction procedure. You should wait at least 2 to 3 months before a YAG capsulotomy is performed. And I always perform that in advance, just in case that does change the effective lens position and the refractive error, and to never YAG a patient who's received a multifocal lens implant or a diffractive optic implant where the patient's satisfaction level was never happy after the surgery. A lens exchange should be considered if there is a poor quality of vision or other miscellaneous considerations of functional vision issues, such as negative or positive dysphotopsias. In considering a lens implant in a patient where the refractive error is large and a relaxing incision or a laser vision correction is not an option, or realigning the patient isn't an option. And then lastly, if that patient is not a good candidate for laser vision correction, whether they cannot wait greater than 3 months, dry eye disease, or they're just a poor candidate in general. And a secondary piggyback lens, considerations would be maybe using a optic material that is opposite of the primary lens implant. And of course, a square edge lens is going to be less preferred to a more rounded optic anterior edge due to iris chafing potential. And in the US, we do have limited options available, but the Sensar lens is a hydrophobic acrylic that does give us the ability domestically in the US to treat both myopic as well as hyperopic refractive errors. So in conclusion, very important to treat that residual refractive error. Find the source and treat that if possible first, specifically ocular surface issues or toric malrotations, and then use the least invasive intervention possible in order to take care of this patient and to take care of their satisfaction level, starting from spectacles in the interim all the way through a lens exchange or a piggyback IOL as warranted. Thank you very much.
Wonderful.
Thank you, Dr. Yu. Interesting options for many patients, or at least those patients that complain about even small refractive defects after surgery are not so uncommon, and we need to have all available options ready. Then we move to the next speaker. I would like to invite Dr. Naveen Rao to talk about IOL power calculation in scleral fixation.
Thank you very much. It's my pleasure to speak today about IOL calculations for scleral fixation. I want to thank Ashvin and Sergio for putting this program together, and I'm excited to join this distinguished panel. I have no financial disclosures in this topic. I want to start by saying that setting expectations is key, because IOL calculation for scleral fixation is definitely an inexact science. There is no IOL calculation formula specifically optimized for scleral fixation, or for that matter, any fixation outside of the capsular bag. And these eyes that we're doing scleral fixation in frequently have limited vision potential. So the consent process is really important. Patients must know that they will still need glasses after scleral fixation surgery. Ocular comorbidities affecting the anterior segment include corneal scars from prior trauma, irregular astigmatism, including large incisions from prior surgery. For example, if an ACIOL was placed in an eye and you have to remove that and replace it with a scleral fixated lens, there can be a lot of flattening or sometimes steepening from sutures placed previously. Corneal edema, because the case will change as the edema changes. Iris abnormalities, including choroidopia, surgical trauma, traumatic mydriasis. And then posterior segment comorbidities, macular edema from prior surgery or malpositioned ACIOL, for example, glaucoma, which can induce, of course, visual field deficits, macular scars, and ptosis from multiple prior surgeries. So these are all things that will limit the patient's vision potential. And okay, you get it, but how do you actually calculate the power for a scleral fixated lens, specifically for intrascleral haptic fixation? So I use the Zeiss CT Lucia 602 lens, which has a labeled A constant of 117.7. And I use an A constant, when I calculate the lens, I use an A constant of 118.4, and I target -0.5. Now, this usually gets me close to a plano result in healthy eyes, but keep in mind that in many of these eyes, there is limited vision potential. So it's difficult to get a sense of what the postoperative refraction is and compare that to the preoperative expectations. You can play with the A constant in the Barrett Universal 2 formula to see how it impacts the predicted refractive outcome. So I wanted to show how to do that. This slide shows in the center panel use of 118.4 for the A constant using the Barrett Universal 2 formula. And you can see that if I was to choose the lens that gives me a expected post-op refraction of -0.5, I would choose a 22.0 diopter lens. But if I was to use a 117.7, which is the manufacturer's labeled A constant, then that same lens, the 22.0 lens, would be expected to give me a minus 1.09 diopter refractive result. And similarly, if I was to use a 119, then that 22 diopter lens, I would aim for minus 0.1, or basically plano. So the point being, if you're using 118.4 for this particular lens, I aim for minus a half. If you want to aim for plano, then you go for a 119 A constant. And then if you want to use the manufacturer's recommended A constant, if you're using this lens, you would aim for minus 1 to achieve a plano result. Now, what's interesting about this also is that if I was to look at the manufacturer's recommended A constant, 117.7, and if I was to choose a lens that would expect to give a plano result, then I would have chosen this, 20.5. But I know that this center panel is usually what gives me accurate results. And so if I had used a 20.5 lens, I would have ended up with a hyperopic outcome. So the point is, you have to just adjust based on what lens you're using and based on your prior results. So haptic fixation and effective lens position. How far you are behind the limbus where you anchor the haptics is what will determine the ELP. For the Yamane technique, I insert the needles for this technique 2 millimeters posterior to the limbus, where the blue line is 2 millimeters posterior to the blue line. For the glued IOL technique, I place the sclerotomies 1 to 1.5 millimeters posterior to the limbus. More anterior sclerotomies will result in a more anterior lens position and therefore a more myopic outcome. And on the conversely, more posterior sclerotomies will result in a more posterior lens position and a more hyperopic outcome. And additionally, trimming the haptics can help improve the IOL centration with the Yamane technique, but because the haptics are vaulted, the more you trim the haptics, the more anterior the optic becomes, and therefore the more myopic result. IOLs with these PVDF haptics, which we like for a number of reasons, are still limited in availability, and you have to order these lenses ahead of time. But that means also that you can't adjust the IOL power on the fly. And that's why I don't think it's a good idea to set the expectations for multifocal lenses, because where you place the haptics and how much you trim them affects the effective lens position. So in summary, IOL calculations for scleral fixation are far from perfect. Aim for slight myopia, adjust based on your own results, and ultimately, please underpromise and tell patients they will definitely need glasses so that you don't have unhappy patients afterwards. Good luck, and please let me know if you have any questions. Thank you.
Thanks, Naveen. Wonderful. That's great information for our patients that need, excuse me, different forms of scleral fixation. And there are more and more of those coming on, the pseudoexfoliation patients, and years later when we need to do the IOL exchanges and we don't have capsular support. So that's a wonderful discussion. I think we're going to have a lot of questions about that. Next is going to be Dr. Rich Davidson speaking about the use of a biometer with built-in central topography for IOL calculations. So Rich, take it over. Thanks.
Thanks very much, Jim. Thank you, Ash and Sergio, for the invitation to speak with you all today. It's really a pleasure to speak with all of you, and greetings from Denver, Colorado. These are my financial disclosures. I do consult with Zeiss, but I have no financial interest in this specific presentation. So, as we know, and we've talked about this a lot, cataract surgery is now a refractive procedure without a doubt. And performing calculations for cataract surgery now requires very precise measurements of the shape of the cornea. And as Dr. Olson mentioned, we have to get the cornea right. And obviously we have to deal with ELP and other things too, but getting the cornea right is key. And nowadays we do use different ways to image the cornea, such as topography, to look as part of our routine part of scheduling a patient for cataract surgery. And I also feel that nowadays, correction of astigmatism is a huge benefit for our patients. We can't have the luxury of ignoring astigmatism. We need to address this, and we're going to have some very unhappy patients if we don't address it. Well, where can things go wrong? Anywhere along this process, things can go wrong. And as you can see, the first thing in this entire process is biometry and keratometry. So if you have bad biometry and keratometry, you could do the best capsulorhexis, but your results are not going to be as good. So we want reproducibility, and here's an example of just, when you're looking at axial length, these two measurements are within 10 microns. Here's an example of looking at keratometry. There's 0.02 difference in diopters in the difference in keratometry. So we want accuracy and we want repeatability in our calculations. And there's different ways to measure the cornea, as we talked about before. On the left side here is placido disc. We also have Scheimpflug. But recently, in the past couple of years, we have something known as total keratometry. And this is different than these other mechanisms because this is actually taking a measurement using a measurement of the corneal surface, as well as using swept source OCT to measure corneal thickness and posterior cornea shape. So rather than using a model for these calculations, we now can replace the model with actual measurements. And that's been a huge change with our practice. And now, even more recently, we have something known as central topography. And central topography provides anterior and total axial power maps based on the telocentric measurement principle and also the swept source OCT. So we're taking not only getting the total, we're getting the total axial power of the cornea, and this gives us great insight. You know, from a efficiency standpoint, we can now look at the corneas very quickly on these scans with one scan only and help determine whether a patient might need astigmatism correction. This technology does not get rid of the use of other mechanisms altogether, meaning I would still advise using your Scheimpflug or your placido disc, whatever it is that you use, but you can get a very good look at the central topography. And it works by using the telocentric keratometry, making an anterior surface model, then using the swept source OCT, measuring pachymetry, modeling the posterior surface, and then it formulates to get the total power of the cornea. So very nice way with one scan to really increase your efficiency. And this is just an example of what the scan looks like. And here's a total power map of the cornea. So which formula do you use? And this gets very confusing, right? There's so many different formulas out there. In our practice, I've just tried to keep it simple. I use the Barrett TK Universal 2 for non-toric. I use the Barrett TK Toric for toric IOLs, and the Barrett True K with TK with post laser vision correction. So it's a little confusing. There's too many T's and too many K's, but this is how I approach it. I just try and keep it simple for our practice because we are tracking all of our results and I don't want to stray too far and cause too much confusion. So all these formulas do use posterior measurements rather than the model used by the traditional Barrett toric calculator. And here's a case example. This is just from a few weeks ago, just in the interest of time. Focus on the left eye. This shows you the power of the corneal topography here built into the IOL master measurements. And this is very nice. This is a 52-year-old surgeon who is like a -9 with her astigmatism that you can see here. These are her Scheimpflug images. And I really like to have the Scheimpflug to kind of correlate axis, but I really am not using this for power at all anymore. I'm using the corneal topography built into the IOL master for power and the keratometry that's built in for power. So it's nice to see that the axis correlates. If I were to use these numbers on the Scheimpflug, it would actually overestimate her power. We have a markerless reference image that can then be sent directly to the OR, and you can align things wirelessly. So you can literally go from the office into the OR, no paper, and have very accurate corneal measurements here. So in summary, corneal topography offers distinct advantages over traditional biometry alone. Better measurements equals better outcomes and happier patients. And thank you very much for your attention.
Wonderful. That was great, Rich. Well, thank you all for all of the great topics that you went over. I would love to have, and we would love to have a discussion now about some of these and maybe some of these questions. Dr. Savini, do you want to begin with some of these questions?
Maybe
I just received the results of the poll that I asked at the beginning. And so the most important need for those that answered is the most surprising to me, to have an instrument able to explain to us the reason of refractive surprises. Actually, this is something that we don't have. I would say, since Tom Olsen is here, that I've been using factor optics to see if there's any error in the prediction of the lens position, because as far as I know, it is the only software working with thick lens that enables us to compare the predicted physical distance of the lens from the cornea from the one that we can measure after surgery. So this was the result of the poll. There are some questions. I don't know if we still have time on the chat. For example, one surgeon, yeah?
as panelists, I would like to give a comment, please.
Yeah.
All right.
Please.
All right. Can I comment on that, Giacomo? You're absolutely right. One of the sources of error is actually the ELP prediction. So what you can do if you have a surprise, you repeat all biometry, of course. You need to exclude any error in the measurements. But if it's an error in the formula, you should identify what the error is. You can do that by measuring the post-op ACD. There are different ways of doing that. You can do it by a slit lamp, you can do it by OCT, you can do it with Scheimpflug. But if you get this measurement, it will tell you right away if the formula is wrong or not. So this is how I do it.
Olsen. For Olsen, for Thomas, I'm personally thinking that your formula will be so useful to help us in many, many years to come. This formula stands tall among Kane, Barrett, EVO, Samus, and Hill RPF. You have 1,000 of data, many publications. That is remarkable invention. This surpasses this limit of traditional IOL calculation formula in effective lens position estimation. As we know that inaccurate ELP estimation is major source of error in IOL power calculation formulas. For example, ELP closer to cornea tends to be higher myopia. ELP further to from cornea tends to be myopia. And as we know, your formula, also formula, incorporates the constant concept to predict IOL position after surgery. This is really good news.
Thank you.
Yeah. And then the second for Navin, the lecture was great. Sulcus fixation is a goalkeeper when something happens. This topic is very needed as a plan B, exactly when someone say, Houston, we have problem. Houston, we have a situation. Because shallow anterior chamber depth tends to be more myopic and more anterior IOL tends to be myopic as well. So I agree that in case of sulcus fixation, we need more than usual IOL calculation. So I hope someday we have a better machine for calculating in the sulcus IOL as automatic feature. And maybe the last for Richard, according to central topography, central topography is a new creative feature based on telemetric precision, keratometry, and swab source OCT. It provides information in central topography right from the start and precise total keratometry. Accounting for posterior corneal surface also important and has effect in total corneal power. It's improved the cataract workflow and with no change in workflow itself, without extra hardware, I think, without extra time, without additional measurement, so easy to use. Awesome. Thank you so much.
Thank you. Thank you so much. Thank you.
Well, this was wonderful. This was a fantastic session. I want to thank Dr. Savini as well as all of the panelists and discussants, and enjoy the rest of the conference. Thank you for having us moderate this session. It's a fantastic meeting. Thanks. Have a great day.
Thanks, everyone. Take care. Bye.
Bye-bye.
Bye-bye. Thank you.
IOL Power Calculation session. The moderators, Giacomo Savini, Italy, and James Katz, USA. We welcome the panelist, Gede Pardianto, Indonesia. And featuring the speakers, Thomas Olsen, Denmark. Elizabeth Yu, USA. Naveen Rao, USA. And Richard Davidson, USA. Organizers: Sergio, Canabrava, Brazil, and Ashvin, Agarwal, India.